Hello, good evening, everyone. I'm Dr. Hina Singla, Program Officer Unit of Vision 2020 India based in New Delhi. On behalf of Vision 2020 India, I welcome you to this webinar cum panel discussion on the topic From Pilots to Policy, Scaling Integrated Data-Driven Diabetic Retinopathy Care Across India. Now, let me introduce our resource person. Our first resource person is Dr. Vivek De. He is the head of Anant Bajaj Retina Institute at LV Prasad Eye Institute. His surgical expertise lies in vitreoretinal diseases. He has delivered over 200 podium presentations and lectures and has 142 peer-reviewed scientific international research publications. He has received numerous national and international awards from the Uveitis Society of India, All India Ophthalmological Society, Asia Pacific Academy of Ophthalmology, and the Asia Pacific Vitreoretinal Society. Our second speaker is Dr. Srinivas Joshi. He is Director of Clinical Services and Head of Vitreoretinal Services. He is trained vitreoretinal surgeon with expertise in both adult and pediatric retinal pathologies. Peer reviewer for several national and international journals, including American Journal of Ophthalmology, Asia Pacific Journal of Ophthalmology, and Indian Journal of Ophthalmology. His clinical interests are diabetic retinopathy, macular holes, retinal detachment, ROP, and artificial retinal implantation. Our third speaker is Dr. Karamjit Singh. He is professor and head of Regional Institute of Ophthalmology in Government Medical College, Amritsar. He is a life member of various national and international societies. He has presented more than 100 scientific papers in international and national conferences and has published 73 papers in various journals. He has awarded he has been awarded gold medal for the community ophthalmology by the government of Odisha in 2013, received award of honor from State Health Department in 2023, Cornea Hero Award by Government of Punjab and PGI Chandigarh, and received Best Performing Institutional Award from State Health Society in 2025. Our fourth speaker is Dr. Rakesh Arora. He is working as an assistant professor in Department of Endocrinology in Government Medical College, Amritsar, and also worked as a consultant endocrinologist in various hospitals. He has multiple publications in international and Indian index journals and co-author of a book chapter. Our last is Dr. Moona Bende. She is a senior consultant and director, Shri Bhagwan Mahavir Vitreoretinal Services Medical Research Foundation, Shankar Nethralaya, Chennai. She is a fellowship trained vitreoretinal surgeon having over 3 decades of experience in managing medical and surgical vitreoretinal disorders and training ophthalmology residents and fellows in vitreoretinal surgery and medical retina. She has 120 peer-reviewed publications, of which was awarded the AIOS IJ Platinum Award. Her special interests are retinal imaging and inherited retinal disorders. The event will be moderated by Dr. Shailendra Sabharwal, Director Public Health and Projects, Dr. Shroff Charity Eye Hospital Network. His area of work include planning, implementation, and monitoring the quality of public health interventions carried out through vision centers, secondary centers, and various projects. He is currently the chair of the Scientific Committee for Vision 2020 Right to Sight India and Vice President of International Society of Geographical and Epidemiological Ophthalmology. He has multiple publications in peer-reviewed journal. He received Hooper's Prize for Best Dissertation in Eye Care at London School of Hygiene and Tropical Medicine and Best Paper in Vision 2020 India Conference in 2018. We are also thankful to Orbe Cybersight for providing us the Cybersight platform. We appreciate the support from our corporate advisory board members, Appaswamy Associates, Orolab, SLO Luxottica, Forest, and Microflow for their continuous support. There is a question and answer box where you can type your questions and we will answer them at the end of the presentation. Thank you once again for your participation. Now I would like to request our first expert, Dr. Vivek De, to speak on the topic translating updated DR guidelines into scalable model of care. Over to you, Dr. Vivek.
So good evening, everyone. Thank you, Vision 2020 Right to Sight India and Dr. Singla for having me on board. So amongst the various endeavors which are on, I have been asked to speak on translating updated diabetic retinopathy guidelines into scalable models of care. I do not have many slides. I will just give a bit of a concept that I have in my mind, and then maybe we can have some fruitful discussion following it. So we know what is the importance of diabetic retinopathy management. It becomes very important because diabetic retinopathy is one of the leading causes of blindness in India. It is one of those diseases where we say, prevention is better than cure, because it is easier to screen and pick up this disease when either it's not existing or it's in the early stage of its evolution, and help patients hold it back there and downgrade it rather than be trying to deal with its complications later. So currently, if we see, there are over 77 million diabetics in India, and around 10 million of them have the risk of severe sight-threatening diabetic retinopathy. Now, diabetic retinopathy runs in various stages, right from a non-proliferative stage where you just have small microaneurysms and few hemorrhages in the retina, right up to high-risk proliferative diabetic retinopathy, where you can have tractional retinal detachments, you can have vitreous hemorrhage, you can have neovascular glaucoma, and all of these can lead to complete vision loss. And now, with changing lifestyles, more and more of the younger population is becoming diabetic. And if we have any of these go into these stages of eye damage, then we are not only sort of having an additional patient of diabetic retinopathy, but we are having a patient who's in the working population of the country, the young population, which is the future. And this is where the importance of having guidelines and implementation becomes extremely crucial and important. What I feel is, as far as these guidelines are concerned, we just launched the new updated diabetic retinopathy management guidelines. It is important to develop diabetic retinopathy task forces. And these task forces, according to me, should be at various states. In fact, they should be at various district levels where we can involve district hospitals, we can involve local private practitioners, and with this, create some sort of a group which helps implement these guidelines in their particular area. So, if the country is divided into states and districts, and in each of these areas, we can identify local stakeholders which can go out in the community and help implement these guidelines. This will actually ensure the last mile delivery of these guidelines into practice. What also becomes important is the reach of all of these task force individuals into the actual population. Now, we now being the most populous country in the world, it is difficult to reach out to each and every human being by a fellow human. So this is where artificial intelligence and teleophthalmology comes into picture. So a lot of large institutes, I'm sure Shankar Netralaya does the same, Arvind Eye Institute does the same. And we also have a setup now where for ROP as well as for diabetic retinopathy, we have teleophthalmic screening programs in place where distantly located people right in the smallest villages are screened by fundus photography, and those images are sent to a command center, which could be either one of our secondary centers or tertiary care centers, where an ophthalmologist or even a trained technician would go through them and then classify the patient as to having diabetic retinopathy or not having diabetic retinopathy. And then at a second level of classification, one can look at whether this diabetic retinopathy requires just counseling or requires therapy. This information is passed on back to the worker on the ground and is communicated to the person getting screened. So that way, we not only reach out to as many people as possible, but we also rationalize the usage of our resources and take maximum leverage of currently existing technologies. So at this is what I talked of being at the absolute ground level. If we rise a bit higher at the district levels, what is important is these screening facilities should be there at each and every district level. We tend to have district hospitals. We often have primary healthcare centers. We have government clinics. So while the rationale of having them could be in relation to mother care or child care or possibly giving information and therapy for tuberculosis or malaria, one could use the advantage of this government set up facility and embed the diabetic retinopathy screening program into it. So herein we would have a structure which is pre-existing. We do not really require to reinvent the wheel, but just add one more layer of diabetic retinopathy screening to the currently existing health facilities that the government is providing. Another thing important is to have an absolutely robust referral chain, because one cannot screen if one is not going to give a therapy. So when you screen these individuals, you will have a chunk which will require therapy. Now, there has to be an appropriate referral chain upstream where these patients can then be referred, where they can get that absolute appropriate treatment. And for everything at each and every level, appropriate financing has to go in, so that we can rationalize the expenditure. We can ensure that the bare minimum required armamentarium in terms of human resource and in terms of technical machines and know-how is there and present at all of these centers. So while we can have referral networks in various ways, one, I would say, not the most important, but one very effective model is the one that we use here at LV Prasad Eye Institute. In fact, this is something that is also adopted by the World Health Organization. So here in LVPI, where I'm sitting right now, which is our Hyderabad center, is what is called as the Center of Excellence or the Quaternary Eye Care Institute. So this is where we have cutting edge tertiary care facility, and there is additional cutting edge research that goes on. If we go one step below, we have tertiary eye care centers, which again have the best of tertiary care facilities, which are across our centers in Bhubaneswar, Vishakhapatnam, Vijayawada, and Kadapa. Below that is our reach into the districts and cities and towns. So those are the areas which we call as secondary eye care centers. They classically serve a population of 500,000 to 1 million population, and each secondary center has an ophthalmologist. Some secondary centers have more than one ophthalmologist manning them and handling the entire eye care there. Now they take care of cataract and they also take care of retinopathy screening. Below the secondary centers is what is based called as vision centers, which serves every 50,000 population across the states of Andhra Pradesh, Telangana, and Odisha. At these centers, we have eye technicians who have been trained, and these eye technicians are able to pick up abnormalities in the eye, and then they refer that information via teleconsultation to our doctors in the secondary and tertiary center. And that way, we can rationalize the screening and referral across the pyramid. Right at the base is a community-based eye health, which serves 5,000 population. So there is one person per 5,000 population who moves door to door and actually inquires about the eye health and also inquires about systemic diseases of hypertension and diabetes. And if there is any red flag that gets raised at that level, it is appropriately referred to the vision center. So everything gets managed at each center, and anything which requires higher level of care is actually moved up the pyramid. These guidelines, which have been proposed in the new document that recently got released, it's important that in all of these endeavors, we have the basic facility of fundus camera. That way, we can capture the retinal health, document it well, and that image can then be transferred to a specialized surgeon who can comment on them. Plus, these images can also be transferred to AI softwares, which can identify whether the eye is diseased or not and actually give us an image review. This can help us decide whether we require a referral for the patient and can also help us decide, if we do not require a referral, what could be the frequency of review that this patient requires in the clinic again. What is also important is to include diagnostic standards. So we can have standard photographs which indicate what a healthy retina looks like, what early diabetic retinopathy signs look like, what advanced retinopathy looks like. So that can help the local volunteer or the local worker in small villages and districts compare the photograph that the patient is having to these standard photographs and take a call whether a particular patient requires an appropriate referral or not. Treatment modalities, as far as diabetic retinopathy is concerned, fall in the purview of either laser photocoagulation and or anti-VEGF injections which are given inside the eye, and in advanced stages of hemorrhage inside the eye or detachment of the retina, we have to fall back upon a surgical maneuver called as vitrectomy. So while it may not be easy to offer vitrectomy in terms of qualified retina surgeon at each and every station, it is important, at least at the district level, to have the facilities of laser photocoagulation and anti-VEGF so that appropriately patients are referred for this to the district level. And anywhere above, there could be designated centers where additional financing can go in and a setup of surgery is put in place. So that way, along the referral chain, one would be able to give medical as well as surgical management for these patients. While we do this across the country, one important thing that comes into picture is to have a unified protocol. So if ABC at a particular area sees a patient, their referral criteria should be equal to the referral criteria in a particular different area. So that ensures that there is consistency in care and nobody really falls out between the cracks and everybody gets a similar level of diabetic care as per the uniform guidelines. When we talk of trying to implement this, it is important to look at who will give this therapy or who will give this care. Now, it is near impossible to have an MBBS trained doctor at each and every station, right down till the district and the village level. So, this is where we need to come up with some basic qualification that a person may be having, say, could be 10 plus 2, or somebody who has done some BSc program, or somebody who is, say, possibly Ayush trained, and they can then be offered training courses where they can take fundus photographs, they can classify images, and they can help appropriately triage patients up along the chain. This can be a formalized process wherein we can actually certify them. And like I had mentioned during the live program in Delhi a week or so back, we should give these people an appropriate sort of career path. So if I get someone from the community locally who has been trained and certified to do this, they would be happy to come into the program, come on board, start helping us with the screening. But it's important that they have a career path so that they can also progress along their career. And that way they stay more motivated to be a part of this entire sequence of events rather than be of help to us for a while and then we face attrition. AI is something which we should look at integrating wherever possible, along with validation audits to be sure that we are getting the appropriate information. And right along the chain, top to bottom, each and every level, there should be a continuous education that keeps going on because all of these modalities are ever changing. They keep getting better and better. So each and every healthcare provider that we assign along this chain should be abreast with whatever is the appropriate guideline for management. In the end, we should also have appropriate monitoring and evolution and evaluation. And finally, we should come down to specific key performance indicators. So, say amount of time into the program, we should have a breather and look back as to how the program had performed, comparing it or evaluating it to key performance indicators that we would have assigned at the beginning of the program, which then helps us take an entire review to see whether the program fanned out the way we wanted or do we require any corrective measures to come into picture. So thank you so much. That is all from my end. I'll be happy to take questions either now or at the end of the program as we might deem appropriate. Thank you.
Good evening, everyone. At the outset, I would like to thank Vision 2020 for giving this opportunity. It was a nice talk by Dr. Dave. So I'll be speaking. The topic given to me is quality outcomes and registries, building a data-driven DR program. So, what are the clinical registries? That is very important to know first. So, we all know that these are the large observational databases, to systematically collect the information and from the real world data, that is from the patient population. So, why maintain the clinical registries? Enhances the quality of the care, and along with that, if we have the benchmarks provide a performance. So what do we mean by the benchmarks is they establish the standards, that is what are the best practices, then measuring the current performance by collecting the data and comparison, and then analyze it so that we can have the implementation improvements, and then to track the process as Dr. Vivek was mentioning in the last slide. So, the definition of this is the process of comparing a healthcare organization performance practices and outcomes, and identifies the areas of improvement. So, which involves the measuring of the key metrics to set the goals and implement changes to enhance the quality of the care, that is, patient safety, efficacy, and many others. So that leads to the improves the patient outcome based on the robust evidence. So evidence is very important for us to make any changes in these national registries. So what is the need for the DR registry now? I think we can have the topic discussion at the end, where I don't know if we have to suggest diabetes to become a non-communicable notifiable disease, because in US and in most of the parts in Europe as well, where they have a national registry where they can get a call. So here we have multiple institutions, single base practice, private institutions. So how do we try to collect these information and put it in one portal is what is the challenge faced by many Indian doctors. So we know that in India there are around 101 million people with a diabetes, and projected to raise up to 150 million by the year 2050. So we all know that India is the diabetes capital of the world. So 21 million visually impaired, 2.4 million blind because of diabetes. So what is crucial for the tracking is why it is important is because to know the prevalence, incidence, and the management of diabetic retinopathy. So the screening of this up to the treatment, that is, it provides a comprehensive view of the patient journey, right from the screening to the treatment. So that's why it's important for tracking these patients with diabetes, especially for the diabetic retinopathies. So implementing the program, I think is very important. Here, if we see, defining the goals and the objectives is important. That is, clearly outlining the registry's purpose. Why is the registry required? We know that it is required for the monitoring, safety, assessing effectiveness, and QIs. So the designing of the registry should plan the data elements to be collected, that is leveraging existing sources like EMRs. Now, every single practitioner in India is also using an EMR. So using these collective data through the EMRs where it is possible to reduce the burden. And then, of course, addressing the legal, ethical, and the privacy considerations, where even when we try to load it through the digital registry also, and a lot of ethical and the legal issues are very much required, and we can definitely look into that when we are doing it, because that is what is important for establishing the governance. That is, set up the infrastructure for data collection, storage, security, and the quality assurance is very important. And then finally implementing a data management plan, that is regularly analyze the data to produce reports and the benchmarks, and then feed these insights back to the providers. There has to be a continuous drive for the improvement. So without the data, we cannot have these continuous drive for improvement in the quality or in the outcomes of the care. So analysis and feedback is also a very important tool in while we are maintaining the DR registry. So integration into the EMR, I think this is a very basic thing. EMR has to be there, ensures that all healthcare providers have access to a patient's full medical history. This is something again which is challenging, because the patient, if is in Hyderabad and then comes to Hubli or goes to Chennai, then we don't have the full access of the medical history of that patient. So the EMR, integration of the EMR and try to unification of these EMRs, that streamlines the data entry and improves the coordinated care. The most important thing is it reduces the redundant data collection. That is very, very important part of the EMR where we need to look into while doing the DR registry. So contributing DR data from EMR to non-communicable disease information system, I think it has two advantages. One is it helps the public health officials monitor the burden of DR at the national level, regional level, the state level, district level, as what Dr. Vivek was mentioning about. So it helps the public health officials, the public, the government also, because what we see now, most of the things are now seen by the private institutions rather by the public institutions. So it's an important for the public health officials also to know what is the burden of the DR when they are actually screened at most of these private institutions. Second thing is it allows for the high level policy making. So with this data, they can make a high level policy and the resource allocation where to allow. Now, the focus is mainly, while on the TB, hepatitis, measles, malaria, all of these, they have the officials for that. But I think the time has now come where it comes under the non-communicable notifiable disease, and then we have to have the resource allocation, human resource from the public health officials also to monitor the aspects of diabetes or diabetic retinopathy. So what are the parameters to be monitored? One is the process indicators, that is the screening coverage, that is the percentage of the diabetic population who are actually receiving annual DR screening. What's the referral rates? That is the timelines and the appropriateness of the referrals from primary care to the either to the secondary or the tertiary care is very, very important. And then treatment guidelines, that is time from diagnosis to sight-threatening diabetic retinopathy. It's very, very important to know the timeline for the treatment burden as well. So next, coming to the outcome metrics, we all know that visual acuity outcomes is most important in any of these diabetic retinopathy, changes in the BCVA, post-treatment, and reduction in the blindness. That is the primary goal of preventing visual loss due to DR. And the percentage of the patients whose diabetic retinopathy stage stabilizes post-treatment or improves after the treatment is what we need to look in for the outcome matrix. Now, how to monitor these cases? I think uh, the three main headings I would like, if I'd like to put it across, is the dashboards, the audits, and the feedback loops. When we look into the dashboards, interactive real-time dashboard, any EMR provider, I think will have a dashboard, a snapshot of the program performance, how the program is running. So this quickly helps the managers or the clinicians to identify how the trend is going, where is the bottleneck happening, and then which sector needs immediate attention for the corrective action. I think these are important elements when we look at the dashboard. The second thing is auditing. Auditing is very, very important to verify the accuracy of the information. Otherwise, we have collected thousands and millions of information and then get to know that, oh, this link was missing, oh, this column was missing. So the accuracy of the information has to be audited regularly and assess adherence to the clinical guidelines. I think this is very, very important because though we have a lot of diabetic retinopathy or DME, various guidelines are there, but still there is no uniformity in the treatment as far the physician or the retinal surgeons is concerned. So we need to have a good adherence to the clinical guidelines where most of us follow the same guidelines as similar as possible. And then the feedback loops, that is the structured process for delivering the audit results back to the clinical teams. I think this is very, very important. Otherwise, the clinicians keep doing the work and the people and the public health officials keep collecting the data and the policy making keep making the policy. So if all three are not in the circuit, then how the correction should happen? It becomes very difficult for the clinicians to know where we are going wrong or how better we can do so that it passes on to the next level smoothly. So this closed loop system allows the teams to implement the corrective actions, monitor the effects of change, and foster a culture for continuous quality improvement. Now, in summary, I would just like to show here in the final algorithm, data-driven decision making, that is DDDM via the EMR. I think the core of the program involves using the gathered data into the EMR to inform the clinical and the administrative people so that they can take some decisions, informing the practice, that is providing practitioners and policymakers with up to date real world information on the disease evolution, its treatment effectiveness, its efficacy to guide the decision making. And then the quality improvement, of course, because sometimes the benchmarking performance against the national or the gold standards and pinpointing the opportunities for improvement is very, very important. So we need to have this quality improvement, which the EMR or the data driven decision making will help us to achieve this. And then, of course, for the research and the policy making is very, very important, using aggregated non-biased data for the research and to inform the healthcare policies that is potentially assisting with the healthcare organizations and the regulatory decisions. So just want to show a snapshot at how we are doing it. So now if I try to enter it from the date, from which date to which date, say for example, in the month of January or December, whichever month we take it up from 1st November, and then now I do it for 1 year data, I put it as a PDR, then you look for the search, and then now you get a complete list of how many patients, where are they, and then some electronic medical records you can just try to notify it, you can export it, which I'll be coming to the next screen, where you can see here various diagnosis all comes into the one line, and then pressing this, I think it's visible, this is the icon which we have made. So pressing this, it goes into the Excel sheet. So this Excel sheet can actually be shared with the registry. So it has a particular information where if you don't want to tell about the patient information in particular, so you have a specific star asterisk made where only those data is collected, and that probably it can be shared to one unified platform. I think that is where we can make changes, we can make rules, we can make regulations so that we can handle this diabetic retinopathy more better. I think I would like to acknowledge my colleague Dr. Shailesh, and then thank you very much. I would love to discuss and learn more from the panelists. Thank you.
So, after these two talks by the eminent ophthalmologists, my talk is basically reaching the rural, low resource, and high risk groups. So, how we can implement the policies made by the various governments to reach the rural and low resource persons. So diabetic retinopathy, as we all know, that it is a leading cause of vision loss. And according to the recent data, there are approximately 101 million Indians diagnosed with diabetes mellitus. And out of this, 21 million people with diabetes are either visually impaired or some are blind. So this incidence, it is more in rural areas as compared to the urban population. So there are various barriers which we encounter, especially in government sector, to cater the diabetic retinopathy group in the rural as well as in low socioeconomic status persons. These are basically geographic isolations, lower socioeconomic status, and lack of healthcare providers in the rural areas, especially in the border belts of India. So these key barriers are most important is distance and travel. Sometimes we receive the patients from far away places to our institutions, and sometimes even when we are going for distant screening programs, we find that these persons, the patients with diabetes or with diabetic retinopathy, they fail to come to our institution for treatment purposes. Of course, finances is a very important factor in the rural and low socioeconomic persons. And lack of ophthalmology and optometry services. We all know that the ophthalmologist and optometrists these days they are concentrated in the cities only or in semi-urban areas, but in the rural areas or in the border belts of Punjab, J&K, Himachal, and even Rajasthan that we have seen. So there is disparity of the ophthalmologist between the rural and the urban population. And of course, illiteracy is one of the important factor, and lack of coordination between the ophthalmologist and medical specialists. And there are few local myths that also affect the treatment of diabetic retinopathy or even treatment of diabetes in those. Uh, so we will discuss the individual level barriers, why the persons from the low socioeconomic status or from the rural areas, they are not coming for the treatment of the diabetes. So low socioeconomic status in the rural and high risk group is one of the individual barrier, and this is associated with unhealthy eating habits. So we observed that in rural or in few of the semi-urban areas, there are unhealthy eating habits of the persons, and there is uncontrolled diabetes. So there are more chances of development of blinding diabetic retinopathy in those persons. And also frequently travel every 3 to 6 months for treatment or even earlier, it becomes impractical. And also in rural areas, there are isolated individuals without any attendant, and they fail to come to the higher centers for treatment without the attendants. And of course, lack of physical exercise is a very important factor that Dr. Rakesh will highlight. And there are community level barriers. So there is a disparity in distribution of eye care professionals in urban areas and in rural communities. Even the optometrist, they are concentrated in the urban or in semi urban areas, not in the rural areas. And also this adds to challenges in assessing the timely care, increase in the likely to be delayed diagnosis and poor outcome in the rural areas with diabetic retinopathy. And also in rural areas, distance and travel present significant obstacle for diabetic retinopathy patients. Now there are important systemic and policy level barriers also. Of course, lack of healthcare coverage in a rural area, which is an important factor. So this should be taken care of at the policy levels. And the combination of lower socioeconomic status and need for costly repeated treatments like injections, lasers, which makes diabetic retinopathy challenging in rural residents. And the lack of regular eye examinations and limited awareness of diabetic retinopathy screening in rural areas, which leads to delayed diagnosis. And even the private healthcare facilities, they are present in the urban or in semi-urban areas only, and these private healthcare facilities are lacking in rural areas. This is also one of the important factors. That's why the incidence of diabetic retinopathy is little bit higher in rural areas as compared to urban areas. Even we are receiving patients with almost negligible vision in patients with diabetes, and those persons, they are coming first time to our department for screening of their eyes. Now, what are the potential solutions for this? The most important is strengthening of the rural health setup with deployment of more medical specialists, optometrists, and ophthalmologists. This should be taken care of at the policy level, where the government should decide to rationalize the deployment of optometrist and ophthalmologist in the rural areas. And of course, regular health screening programs with regular checkups of blood sugar, blood pressure, and screening for diabetic retinopathy is very important. And it is also important to mobilize the paramedics. Those are already present in the rural areas. Various optical shops, Ayush persons, which are present these days in almost all the rural areas and semi-urban areas. And of course, Anganwadi workers who are part of that community to impart knowledge of the regular checkup of the diabetes and of course of diabetic retinopathy. And rural incentive programs should be taken care of for medical as well as paramedical workers in the rural areas. This should also be discussed at the policy level. There should be some incentives to the medical as well as paramedical workers who are working in the rural areas to take care of the load of the diabetic retinopathy in rural areas. And of course, education is very important. Education, which is not so much in the rural areas, educational initiatives should be started uh, for diabetes as well as diabetic retinopathy. So this strategy involves training the community members as health educators. Like there are so many educated persons in the rural areas. Those educated persons in the rural area can play a very important role in educating the local community in their language to impart knowledge about the diabetes and the diabetic retinopathy. So another approach is basically in there are primary rural care providers in the rural area, either RMPs or either Anganwadi workers or other Ayush workers. So they should be trained. They should be given knowledge about the diabetic retinopathy in that area so that they can educate the local community. And additionally, various awareness campaigns with the rural community can boost the public knowledge about diabetic retinopathy and encourage routine screening. So here we can take help of various NGOs or various other local local leaders present in the communities, like various deras, various gurdwaras, various other mandir and like that. So we can spread awareness about diabetes and diabetes retinopathy through that community only. Now, enhanced training programs. So it is also important. The ophthalmology residency program could provide a more extensive training in intraocular injections so that all newly graduating ophthalmologists they should know that how to inject the intraocular injections, how to do laser, how to screen for diabetic retinopathy, and how to manage those patients with diabetic retinopathy, when to refer those patients to the secondary or tertiary care levels. Secondly, training residents in the remote locations could prepare them to work effectively in settings with limited resources. And also, continuous education courses on various modalities of treatment of diabetic retinopathy like injections and lasers should taken care of at tertiary care or at the various private hospitals which are giving treatment to the diabetic retinopathy persons, various retina clinics like that. And by implementing such intervention, the healthcare system can enhance access to advanced treatments in the rural communities, which is lacking in the rural community. So this improves the patient care in the rural community. And teleophthalmology is, as discussed, the role of artificial intelligence and teleophthalmology. It is very important, and it is a very important tool to screen the diabetic retinopathy and to refer the patient from the rural areas or from the even semi-urban areas to the base hospital. So teleophthalmology emerged as a promising solution to bridge the gap in rural eye care for diabetic retinopathy. So mobile screening units can enhance access to care for the remote population. So these mobile health screening programs are very much in practice in many areas of India, in many areas of even Punjab and adjoining J&K. And virtual consultative services can help minimize unnecessary travel for follow-ups and treatment with retina specialist, which sometimes is very important. And lastly, home monitoring devices capable of detecting visual changes and altering healthcare providers can also contribute to better diabetic retinopathy management. Like when we are going to the camps, so we give simple Snellen chart at few of the common places, so that, and also we educate the person over there how to check the visual acuity of the person. So they are routinely advocating the local community to come to that place and check their vision routinely, if patient is, whether patient is a diabetic or non-diabetic, and if there is any diminution of vision or person notice that the vision is not proper, then he or she can come to the base hospital for visual acuity checkup. So this we are regularly doing. And of course, role of artificial intelligence these days, it is the artificial intelligence screening tool, it is an emerging tool which can help a lot in management of the diabetic retinopathy in rural populations. We have seen so many models of artificial intelligence screening in India that are in place um, in at various places, but it should be developed more, and it should be accessible to more of the centers in India, so that we can screen the diabetic retinopathy at appropriate time, and we can refer those patients to the base hospital for management of those that diabetic retinopathy. So to conclude my talk, diabetic retinopathy remains a key health concern in rural and low socioeconomic status communities who face multiple barriers in access to care, including physical distance, which is there at in the rural and border areas of various states, socioeconomic factors, and healthcare provider shortage. So a variety of potential solutions are available to confront these issues, such as telehealth or teleophthalmology, artificial intelligence screening, and targeted education and training programs related to workforce issues. So, in order to enact these solutions, a comprehensive multi stakeholder response for policymakers, healthcare system, educators, and technology developers will be required to best serve those in rural and low socioeconomic status communities. So, thank you very much.
Today, I've been assigned the responsibility to talk on the topic, that is optimizing diabetes and non-communicable disease management to prevent diabetic retinopathy, and with a focus on priorities for the eye health community. So my job has been made relatively easier by the previous eminent speakers who have covered most of the topics. So I'll try to cover this topic under these headings. First, I'll talk about a little bit about the burden and rationale. Then I'll talk about the key evidence that links the risk factor control to the onset and progression of the diabetic retinopathy, a little bit about the screening, and the priorities that should be put in place both at the clinical level and health system level, and practical tools for the ophthalmologist, and a final call to action. So this has been discussed already. It's a leading cause of the new onset blindness in patients with diabetes mellitus. And in 2020 alone, by 2020, more than 103 million individuals worldwide, they were affected. And this number is expected to increase to 160 million by 2045. And it's the only condition that leads to blindness which has not experienced a decrease in the age standardized prevalence between 1990 to 2020. And many of these cases, they are preventable with a systemic risk factor control. And ophthalmologists, they form a key link to the early detection and linkage of these patients to the non-communicable disease clinic care. So the systemic risk factors which are responsible for the onset and progression of the diabetic retinopathy, they include, first and foremost, is the hyperglycemia itself. Most important factor amongst the hyperglycemia is the duration of the hyperglycemia. So longer the patient has diabetes mellitus, the higher is the risk of developing uh, diabetic retinopathy, and higher is the risk of progression of diabetic retinopathy. Second is degree of hyperglycemia. So if the HbA1c or the long-term control of diabetes mellitus is poor, then there are higher chances of onset as well as progression of diabetic retinopathy. And glycemic variability also has an adverse effect on the progression of diabetic retinopathy. The other systemic factors that can contribute to the progression of diabetic retinopathy, they are hypertension, dyslipidemia. So if we talk about the levels of HbA1c versus the risk of diabetic retinopathy progression, so there is a linear relationship. So as the HbA1c increases, the relative risk of diabetic retinopathy also increases. The other risk factors, they include concomitant nephropathy, smoking, higher body mass index. Puberty has a higher risk of, uh, nowadays we are seeing many adolescent patients with type 2 diabetes mellitus, even as early as 10 years, 12 years of age, they are developing type 2 diabetes mellitus. So during puberty, the the diabetic retinopathy can progress in such patients, and also in patients with type 1 diabetes mellitus who have an early onset of diabetes mellitus, and uh, uh, they can witness a progression of the diabetic retinopathy during pivotal stage. Then a cataract surgery can lead to an increase in the diabetic retinopathy. So there are certain sex-specific risk factors. Women, by and large, they are at higher risk of developing or progression of diabetic retinopathy as compared to women, and more so during the pregnancy. So pregnancy, we'll discuss later on the criteria for pregnancy for screening of diabetic retinopathy during pregnancy. They are more stringent. We need to be more frequent during for the screening of diabetic retinopathy during pregnancy. And there may be some underlying genetic determinants also. So it has been observed that many of the patients who have highly uncontrolled diabetes mellitus, they may not even go on to progress to develop diabetic retinopathy even after prolonged duration. And many of the other patients, they may have a shorter duration of diabetes mellitus, which may not be that poorly controlled even, and they may develop diabetic retinopathy. So there are certain genetic determinants also which may be at play. So this is a slide which shows the evidence of these risk reductions of the key systemic interventions. So there have been major trials like TCCT, which was the trial in type 1 diabetes mellitus patients. Then there are other trials like UKPDS in the type 2 diabetes mellitus patients, and ACCORD and FIELD trial. So the maximum benefit is with the intensive glycemic control. And the next in line is the tight BP control, and least evidence is with the lipid control. But nevertheless, all these things should be the effort should be made to keep all these things under appropriate control. And then intensive glycemic control has a what we call as the metabolic memory effect. So it was seen that patients in DCCT and UKPDS trials who were subjected to intensive glycemic control, even after the intensive glycemic control was lost, the progression of diabetic retinopathy was the rate of progression of diabetic retinopathy was lesser as compared to the conventional arm who never received any form of intensive glycemic control. So, screening, it is necessary to detect the referable cases, and the patients need to get a timely full ophthalmologic examination and then treatment to avoid permanent visual loss. Who should be screened, when should be, the screening should be done, and how it should be done? This is the American Diabetes Association screening recommendations for diabetic retinopathy. So patients with type 1 diabetes mellitus, they should be screened within 5 years of the onset of type 1 diabetes mellitus, and they should be followed up at least annually. So this frequency can either go down or up as the case may be. If the multiple follow-up examinations, they do not show any evidence of diabetic retinopathy, then this interval may be increased. And if there is any evidence of diabetic retinopathy, this interval may be decreased also. For type 2 diabetes mellitus patients, because there may be a certain period of undiagnosed disease, the recommendation is that right at the time of diagnosis of type 2 diabetes mellitus, these patients should be screened for presence or absence of diabetes retinopathy. And then again, they should be followed up at least annually, which again can be increased or decreased. The interval can be increased or decreased as per the case scenario. The pre-existing diabetes and planning on a female patient who has a pre-existing diabetes and she is planning to get pregnant, then ideally she should have a fundus screen before pregnancy and then during every trimester. So every 3 monthly she should have at least 3 fundus exams during the whole of the pregnancy, and then after the delivery, up to 1 year after the delivery, another fundus examination should be done. And for gestational diabetes mellitus, so it is also important when not to perform these fundus examinations, to not to overburden the already strained healthcare system. So the patients who have gestational diabetes mellitus, they do not require any fundus examination. So the clinical priorities that should be in place for the ophthalmologists, they should ensure that there is timely annual or risk stratified diabetes retinopathy screening and timely referral for the systemic care. They should try to document the HbA1c, BP, and lipid status whenever possible, and then create a feedback loop with the diabetes or non-communicable disease clinic teams. And if feasible, then they should also incorporate brief counseling messages on the glycemic, BP, and lipid control. And they should emphasize the adherence to the medications for these diseases. And lastly, they should try to coordinate for a multidisciplinary care. At the level of the health system and policymakers, the priorities they should include integrating the eye screening program into primary non-communicable disease services and diabetes clinics right at the first point of contact. The training the primary care physicians to detect the sight-threatening diabetic retinopathy and fast-tracking these referrals, establishing robust data systems to track the screening referrals and outcomes data, and advocate for the affordable diagnostic and essential medicines. So the tools and innovations that can be used to scale these preventive screening programs, already these things have been discussed. So AI-assisted fundus screening programs can be done. Then portable fundus cameras with telemedicine can be done. Smartphone-based retinal cameras can be utilized, and point-of-care HbA1c and BP measurement in the eye clinics to close the care gaps. And finally, the call to action for the eye health community should focus on building formal links with the diabetes and NCD care teams, implementation of risk-based screening and documenting the systemic risk factors, collecting the outcomes data and participation in the implementation research and advocacy of the policies that ensure access to essential non-communicable disease medications and diagnostics. So, thank you for your patient listening.
Thank you, Dr. Hina. And thanks to all the speakers for their excellent talk. Maybe Dr. Rakesh, you can stop sharing the screen. So I think because we have limited time, what we can do is we can I can start with certain questions addressed to a specific panelist, but to the others, I invite them to basically definitely come in if they feel they have something to add. So I think the screen is still getting shared.
Yeah, Dr. Rakesh, you have to stop share the screen. It
So
That's
maybe,
just a yeah, red green one, and the yeah,
yeah.
it's okay. Yeah.
So I think the first question that I would like to put is to Dr. Bhinde, that we saw in Dr. Vivek's talk about policies and guidelines. What policy do you think, what one or two single or two or three policies that you feel should be implemented immediately or should be changed, and that would have maximum influence in the way we want to prevent vision loss due to diabetic retinopathy?
I think I've enjoyed all the talks and learned a lot from all the speakers. Thank you so much. I think what we need to emphasize is that diabetic retinopathy need not be present with poor vision. By the time the patient presents with poor vision, it is too late off. So I think that emphasis on there could be diabetic retinopathy even with good vision, and every diabetic needs to be screened, irrespective of the duration of diabetes. I think that would go a long way, and with the onus of the physician to just tell the person, go get your eyes checked. And the optician, the pharmacist, everyone just asking one question before giving the prescription, you're a diabetic, did you get your eyes checked? I think that will go a long way because they have a very different level of influence compared to what we have. So I think that will help a lot.
Thank you. Maybe I'll go next to Dr. Vivek. If you have anything to add to that. And also another question would be, yes, Vision 2020 has come up with some revised guidelines, and there were already some guidelines in present. So what do you think, which guideline do you think is important but would be most difficult to, let's say, implement? And how do you propose implementing those guidelines, which might not be that easy to implement?
Right. Thank you, Dr. Sabharwal. I absolutely agree with Dr. Bhende, where, those primary contact people in the society, people whom patients or general citizens meet every now and then, could be real torch bearers to pass on this information. I mean, we wouldn't put the onus on them to screen, but at least pass on that information and tap on the shoulder. Hey, did you get your want to get your eyes examined? And this could also percolate into educational institutes and offices. Educational institutes, I would say, because a child absorbs information quickly, and that child can go back home and convey to parents and grandparents. And offices, yes, there is usually, I would say, annual checkups, but this basic information that if you're diabetic, go and get your eye checked, something that should go in one line. More we can, disseminate this information, nothing like it. So that's as far as that first point is concerned. Second, when you say what could be most challenging, I think there may be some resistance inherently that we may have as ophthalmologists when we try to onboard quote unquote non-ophthalmologists, for the fear that they may be venturing into our domain. How do we be sure that they would only execute the task that we have entrusted them to execute? Or would they cross the line and start going into the domain of treatment? Because many times, a lot of things in our country, because we are a big country, education levels differ, facilities differ, things are often unregulated. So I would say onboarding non-ophthalmologists could have some amount of resistance, or could be one point where we may have some difficulty. But eventually we need to get there, because we are not enough retina surgeons, not enough ophthalmologists, not enough doctors to reach out to the whole population. Second difficult thing, I think, which might be, is to ensure there is penetration of instrumentation, because these are either costly gadgets, or these are gadgets which require some amount of learning to be able to implement them. But here again, if at least in important nodal locations, we are able to push through non-mediatic fundus cameras or AI-enabled technology, it would be really helpful. Last point that I feel is important, I am not very sure to what extent in all state policies is laser or anti-VEGF injection included to give some amount of basic coverage to patients, because somebody may be motivated to get screened because screening is often cheap or free. But when it comes to taking therapy, especially the subset that Dr. Bende pointed out, those who are visually asymptomatic, right? They may not be motivated enough if they feel that there is some amount of expense that is involved. So if these basic treatments also come under the gambit of the government coverage of some amount of money, then again it helps ensure that we get that last mile coverage for the patient. Yeah, thank you.
Yeah, thank you. And I think the first thing that you said, we have to identify, like we've done in other subspecialties, task shifting and task sharing has to be encouraged. And we have to do it with quality, but we can't be scared of that. Yeah, Dr. Bene, you wanted to add something? Yeah.
I just wanted to add, we seem to be talking more and more about training people to give injections, but we forget that, doing one panretinal photocoagulation or one macular laser is probably a one-time event for most people, and they don't need to come back every month. So overall, I think training people in doing indirect ophthalmoscopy, postgraduates, to do simple lasers, I think will turn out economical in the long run rather than expensive injections which require patient to come back every month, because I think that is another thing which we need to think about.
Thank you. Maybe I'll just next go to Dr. Srinivas. Very interesting talk on registry and how to do it. Recently, in fact, we were doing a survey in one of the operational district in UP that we work in. And not surprisingly, we found hardly any organization, any institute, any private provider having data for diabetic retinopathy treatment or screening in a manner which can be shared. So it's a big challenge. But yeah, you showed some of the ways. But what I would like to ask you is, how do you feel, how do you think we can, let's say, encourage the healthcare providers and facilities to share data? How do, what incentive do they have to share all that data? Because that's becoming a major roadblock for any evidence other than what we do the epidemiological studies and because real world data is important, as you said. Yeah.
Uh, I think, Shailendra sir, you have hit on the nail. It's a difficult question to answer. See, majority of the institutions, they have their own data, collective data. Say, for example, now two institutions like LV Prasad, Shankar Nethralaya, both eminent surgeons are here. They do collect collaborative research kind of thing. But when it comes to sharing the actual patient data load, that I think has to be defined. The policy has to be made by that. Just by doing incentivization, I don't think it really happens like that. Although I just looked into one study in the Brazil where familial health program, how they were trying to track it, and how they tried to incentivize the ground level worker, and then how they the reporting used to happen, and how they tried to improve the healthcare system in a smaller country compared to India. And I must say that they have a robust healthcare programs as compared to India. So some those kind of incentivization can be done. But what I feel is some policy has to be made where the diabetes now has to be reported as a non-communicable notifiable disease, and then so that it comes into the registry. So some registry has to happen, means everybody, it has to be a compulsion, not just because of incentivization. They say they respect what you they don't respect what you expect, they respect what you inspect. So some kind of thing, such thing has to happen where compulsion has to be made. You see in US, UK and all those things, it's a compulsion. Even though they have multiple EMRs, but finally the data, they have certain asterisks, and that data goes into the registry. They know what is their diabetes burden, they know what is their ARMD burden, they know what is their vein occlusion burden, everything they know. But you take ICD and most of these classifications, they are so thorough in making it, because right from the beginning they are doing it. But India has now shifted to EMR. I must say that most of the practitioners have shifted to EMR. But I think if we make certain mandatory things from the government or from the policy makers or all the institutions coming together and agreeing, yes, we have to make it a generalized data where the pooling has to happen. And once we start making these pilot studies, then the others will slowly probably try to get incentivized, like, okay, these institutions are doing there. They have changed the way how the treatment was to be done. Because it's not always the vitrectomy or the lasers or the injections which we talk about. It's at the grassroots level, how it is happening. We just did in a slum, we just did a small program, and the most of these quacks were going and telling them, don't go there. They do it just for money. Even though it was a completely free of cost, the lasers were free of cost, injections were free of cost. But these barriers, they try to come across, and they try to dissuade the things whichever is possible in the chain. So I think some mandatory things have to be love to learn from the panelists.
Good. I think that means from my word, I should have changed my word to disincentives should be there for not sharing the data, right? So I think we might have to go around that and see if somebody else has something to add. Please go ahead. Otherwise, I can
Yes.
go to my next question. Yeah.
I agree with Dr. Srinivas Joshi that the data should be shared. Uh, so we have seen in the government sector that there is only few institute specific data with the ministry. So the state specific data should be collected, and that data should be evaluated. So what is the incidence, what is the prevalence of diabetic retinopathy in that state? Accordingly, that the state health department should be sensitized to take care of the load of diabetes or diabetic retinopathy. So we in our national meetings we have seen that the incidence of diabetic retinopathy, it is very high in some states, and it is little bit lower in other states. So there the state specific data should be collected, and it should be shared it should be shared with every state, with every the policy makers, with the other stakeholders in government sector as well as in the private sector to cater the increasing load of diabetic retinopathy in India.
Thank you. Thank you, Doctor. Yeah, Dr. Vivek.
Yeah, one quick point. So whenever anyone asks some for for some data or some information, on the other side, I'm sure there's always a question, why should I give it? What will be done with this? So when a policy like this is being made, or when ophthalmologists are going to be approached with a question that can you please share your data, I think it might be important to spell out very clearly what the government intends to do with this data. Okay, fine. I is it just for academic purpose? I mean, data is asked for, I give data and then it just lies somewhere. So if the government really spells out what is going to be the plan, how that data is going to be used, then once the other side of the table sees the downstream, I think that is when they would likely be motivated to be a part of the endeavor. When I know that, okay, fine, if I give this information, something nice is going to come out of it. Let me be a stakeholder in my small way. By all that is being asked from me is to, give anonymous data at my end with respect to XYZ. Then I think that would work out well. Just asking may draw blank, but if we ask with our plan, then we might, get people on board.
Sure. Thanks. I think one thing I'll add to that is that sometimes sharing data itself is so difficult on the government portals. You need special people sitting there whole day just putting data in. So something which is easy to upload, easy to get from your routine EMRs, and then maybe have an integrated software. Maybe sometime if this ABHA ID is coming in, how do you integrate that with various EMRs without compromising data privacy, so that you don't need special resources to upload that data? Sometimes that in our organization we found a major sort of roadblock, that you have to put special people just doing that, and you don't have so many resources. So yeah, I'll add to that, Dr. Bende, yeah, and then I'll move to another question. Yeah.
I think just a quick question. The fact that we don't have a single ID for a patient, and the Indian healthcare system is such that the same patient goes to 10 different people. So I think that is the biggest challenge in getting data. Because
Absolutely.
if I have to collect data from 5 hospitals in Chennai, it's probably the same 5 patients who are
Yeah.
gone everywhere.
Absolutely.
So I
Absolutely.
think
Especially
that
for
is a
the,
big
yeah,
challenge. Yeah.
especially for the chronic condition. And that's where maybe when the ABHA ID becomes more popular and easy to integrate, maybe all the patients would be on that ID. And I can in my clinic see where they have shown earlier what has been the diagnosis or treatment. And I think that will be the best part. So coming to the community part, Dr. Karamjit, you covered the rural and the resource constrained settings. What I would like to ask you is that, yes, I think one important part in any of quality of any diabetic retinopathy program, which is challenging, is adherence to follow up and adherence to treatment, because it's not a one-time thing. So do you think there is a scope for the community stakeholders in improving that aspect of the program?
Yes, definitely. So various NGOs or various other organizations working in the rural area, they should come forward to help those people who are living in the rural area, or especially in the this border area of the sorry Punjab or adjoining J&K. So I think they should come forward for management of this, for screening of diabetic retinopathy and diabetes as a whole. So sorry, my little bit I have sore throat. So they should come forward to cater that burden only.
Yeah. 'Cause, anyone else? Because adherence also sometimes is not addressed. Even in, I think this time when we were in Delhi, we discussed a lot of indicators, including how many complete their follow-up. And adherence is sometimes not even monitored. So, anybody would like to add something on some policy or strategies to improve adherence to treatment or adherence to follow-up?
this is where I think, I mean, it's difficult to implement on the mass level, but this is where home screening can help. So this is something that we here at our institute have started doing as a fallout of COVID, and we've continued it where very senior citizens, at least, we are not calling them back to the clinic. We screen them with mobile units of refraction, fundus photography, and OCT. So that helps us take decisions, to a great extent. All that information comes back to the treating physician, who then makes a phone call to the patient. And then we rationalize whether they need to come back or they don't need to come back. If they require therapy, yes, we do call them back. If not, then we just have a discussion over phone. So that way, I think a lot of the visits, they don't have to come in physically, and we can get at least some information as against losing the patient out on follow-up.
Thank you. See, we are running out of time. So, yeah, Dr. Bhinde.
Yeah, I think our biggest challenge is to get the working population to come for their checkups, because they have to take leave, and if they need a procedure, they have to bring an attendant with them, and they lose out. Plus, they have to see their physician for their checkups. So I think that is the biggest challenge. So we need to look for treatments which are likely to be more long lasting and do not require such frequent visits.
Sure. Yeah, thanks.
One more thing is, so we should treat that person as a whole, not only the eyes. So we should check that person as a whole, like the status of the cardiac status, the renal status, and the other systemic diseases if present. So sometime a person come to us with cataract surgery, but when we check the fasting or random blood sugar, that comes to be near 400, 350, and that person is basically newly diagnosed diabetic person, and person doesn't know that he is a diabetic. And sometime even on doing ultrasound B scan, we find there is either vitreous hemorrhage or the proliferative diabetic retinopathy, signs of proliferative diabetic retinopathy present. So that person should be screened as a whole, not for the eyes, as a whole, in the rural setup, only by the physician or by the healthcare provider present in that area.
Sure. Thank you. Yeah. Any quick point, Dr. Srinivas? Yeah.
I think Mona Madam touched very important point is where the working class population has to come and get it screened. In fact, in few of our vision centers, we have started this door-to-door D2D. I think Shroff is also doing quite of D2D programs. So the challenge we are facing is our healthcare workers are going with the remedio fundus cameras, and most of these people who are identified as diabetics, they go out to the field to work, and coming back their time is 6 7 o'clock, and by the time these healthcare workers, this most of these are women, they have to go back to their this thing, they never attend at all, because of which even our ABFE has been stuck in most of these villages, avoidable blind free. They are not getting themselves examined, even though when they go to their doorsteps. That is the real challenge we are facing in these rural areas. I think the awareness has to be increased, like how we have this cola, Pepsi, pan masala, all these ads campaign. I think we need to add a little bit about what are the disadvantages of these diabetes, how the sight threatening it is. Try to make it a little more interesting using the social influencers, how it can affect the public, it can affect the society at large. I think these
Agreed.
things have to be stressed
Yeah.
upon.
Agreed. I think we have to see how the health-seeking behavior changes, and we don't keep on running after patients at their doorstep. That, I think, needs a major behavioral change. Uh, Maybe I'll just go to the last question because I'm already getting over time. Dr. Rakesh, what do you see as the major sort of roadblock right now of integration? We always keep on talking about integration of diabetic retinopathy with program with diabetes, NCD program. Where do you see major roadblock in your setting?
So I think most of the points have already been covered. The major roadblocks, they include, first and foremost, it's a fragmented care. So ophthalmologists are looking at the patient from a different perspective. the physicians and endocrinologists, they are looking at the patient from a different perspective. And this has to be integrated. The ophthalmologists, they need to make the patient aware, first screen the diabetic retinopathy, and then make the patient aware regarding the other systemic risk factors that may be contributing to the onset and progression of the disease. So that fragmentation has to be closed. Then obviously there are the lack of the screening guidelines, the a permanent diabetic retinopathy screening, which has to be put in place. And then there are training gaps. Then there are other infrastructural gaps may be present, uh, which prevent the screening of the diabetic retinopathy. Then there can be referral gaps. So patients who are not adequately referred, they may be screened, but they are not adequately referred. And finally, there can be financial and policy constraints at the higher level, which can lead to the inadequate detection and prevention of this disease.
So how does it work in sort of your setting when you see patients? How is it? You are within a medical college, right?
Right.
So how does that work there when you see
So
diabetic patients?
basically, fortunately, we have a very good referral system amongst at least I can say for the endocrine clinic and the ophthalmology clinic. Whenever I see a patient with any kind of diabetes mellitus who is fitting the criteria for diabetic retinopathy screening, I always make it a point that the patient is referred to the Regional Institute of Ophthalmology for a comprehensive eye screening. And same is with the ophthalmology clinic. The patients who are, as Dr. Karamjeet Singh outlined, who are diagnosed to have diabetes, they may not be knowing about their diabetes mellitus. If they are diagnosed, they are referred back to the endocrine clinic. So fortunately, we have a good, but I think the referral gap comes with the peripheral centers. We don't have a robust referral system or a communication system with the peripheral centers. And all those obstacles that I talked about, they need to be addressed more at the ground level rather than at the tertiary level.
Thank you. So I think I'd like to thank all the panelists for their excellent talks and response to questions. I'll just hand it over to Dr. Hina now. Thank you.
Yeah, thank you all for attending today's webinar cum panel discussion. And we appreciate your time, engagement, and thoughtful questions. And we also like special thanks to all the experts who share their expertise. And we also thank our corporate advisory board members for their support. We hope you found the session valuable, and we look forward to see you at the future event. Thank you all. Thank you so much. Thank you to all the speakers, to the moderator. Thank you.